Good morning, everybody. Welcome back to Department of Medicine Grand Rounds. Today's Grand Rounds are in honor of Dr. Robert Glaser. I'd like to share just a few words about him before introducing our speaker. So Dr. Glaser was a prominent physician, educator, and academic leader whose career spanned clinical medicine, medical education, health policy, and philanthropy. He was a native of St. Louis, and he earned both his bachelor's degree and medical degree from Harvard before he came here to WashU, where he started as faculty. He quickly rose to the academic and clinical ranks, became chief of the Division of Immunology and Rheumatic Fever Clinic, as well as the Associate Dean and Chair of Admissions. In 1957, at age 38, he actually became the youngest dean of U.S. Medical School when he was appointed to lead the University of Colorado School of Medicine. And then he had subsequent major leadership roles at Harvard as well as Stanford University. However, he also had a pretty prominent career after leaving academia. He brought his expertise to philanthropy and medical education. He served in major leadership roles for several foundations and trusts that supported both residents, trainees, and physicians in these endeavors. He was also in charge of serving leadership roles for major physician organizations, including the Association of the American Medical Colleges and the Medical Honor Society Alpha Omega Alpha, where he was also the editor of the journal for that society, the Pharos. And he joined the WashU School of Medicine Board of Trustees in 1979, where he served for the majority of the remainder of his career. In 2010, the Robert J. Glaser Visiting Professorship was established to help bring eminent physicians, scientists, and leaders in our field from across the country to share the expertise with their WashU community. Today, we are lucky enough to have a speaker who truly embodies all of the qualities that Dr. Glaser exemplified throughout his life. It's my distinct honor to introduce today's speaker, the Executive Vice President and Chief Executive Officer of the American College of Physicians, Dr. Darilyn Moyer. Dr. Moyer earned her undergraduate degree in biological basis of behavior, biology, and psychology from University of Pennsylvania, and received her MD from Temple University School of Medicine. She stayed at Temple to complete her residency as well as complete a chief year after that. And then she did a fellowship in infectious disease at Harbor UCLA Medical Center before returning to her alma mater at Temple, where she has served as faculty. In terms of her role as ACP, she's been a fellow in the ACP since 2007. She's held numerous leadership roles within the ACP prior to her current appointment, including the chair of Board of Governors, governor of the Pennsylvania Southeastern Chapter, and member of the Board of Regents, the college's main policymaking body. Beyond the ACP, Dr. Moyer holds significant national leadership roles as president of the board of directors for the Council of Medical Subspecialty Societies and the chair of the Primary Care Collaborative. She is a member of Women of Impact and has been recognized with several prestigious honors for her work supporting women in medicine. This includes the Elizabeth Blackwell Award from the American Medical Women's Association, the AMWA's Inspire Award, the American Medical Association Women Physicians Section Inspiration Award, and the Thomas Jefferson University Hospital Courage to Heal Award, among several other honors in terms with honoring her and recognizing her clinical work. Prior to her current role, Dr. Moyer was a professor of medicine and executive vice chair for education in the Department of Medicine at the Lewis Katz School of Medicine at Temple, where she also served as program director for the IM residency and assistant dean for graduate medical education. As evidenced by all of these roles, she has played at Temple and nationally. She's a dedicated faculty mentor and advisor, widely respected for her commitment to medical education and health policy. Her trainees have now scattered across the nation, including here at WashU, and have held her in high regard for their training and mentorship that they have received. Today, Dr. Moyer will be talking about the importance of primary care for our health in our healthcare systems. Please join me in welcoming Dr. Moyer to our Grand Rounds.
Good morning. It's great to be here and to see. I'm a quote wise PGY 40, so it seems that wherever I go, I get to see my former trainees, such as here today. And being both an internal medicine physician and an infectious diseases specialist who's really spent most of her life caring for people living with HIV, as well as in the medical educational arena, I really appreciate the importance of primary care being foundational for our health system. And unlike the surgeons or the emergency medicine physicians, primary care physicians save lives, not over seconds or minutes or hours, but over years and over decades. And it is that heroism of incrementalism, as Atul Gawande, a surgeon, wrote in his New Yorker piece, that we need to celebrate and support. So my disclosures are that I have no disclosures, and want to thank physician and staff colleagues for all the important work they are doing in very challenging times for healthcare. We're going to talk about some data. We're going to go over obstacles as to why frequently our folks that are on the front lines of primary care feel like the Rodney Dangerfield of healthcare, that they get no respect. And so we're going to talk about why it is important that we all care about supporting and lifting primary care, because it allows us to flourish in our given domains of care. I know for a fact that my medical subspecialty friends are all doing primary care because patients can't find primary care practitioners. And we know that they contribute in incredible ways for a variety of outcomes in our system. So, I grew up in the 60s and 70s where Walter Cronkite said things like, America's healthcare system is neither healthy, caring, nor a system. It sometimes feels like this just piecemeal morass of things happening to patients. And unfortunately, this statement really still does hold true. So we're going to talk about administrative burden. We're going to talk about the failure to truly address health and healthcare inequities, physician turnover and brownout and burnout, low-value care, diseases of despair and violence, where primary care practitioners are particularly poised to intervene. And then, of course, the incredible pandemic of mis, dis, and malinformation in healthcare. And I think what's really important is that we give a big shout out overall to internal medicine, which in the most current match was 27% of the matched positions in NRMP 2025. IM is 25% of the practicing workforce and a quarter of the training workforce. However, we are seeing a shrinking number of folks choosing to go into general internal medicine, those 3 years of internal medicine training. And we really rely on our internal medicine folks because, as you can see here, see if I can do the pointer right, we have almost as many general internal medicine docs on the front lines as our family medicine colleagues do. ACP has been very embedded at the RUC, and we're going to talk about that in a little bit. The RUC is that committee that is set up to advise on payment. And unfortunately, rather than the RUC being designed to be proportional to the practicing physicians in the United States, it has one slot per specialty. So small specialties that only have several hundred physicians in that specialty have the same power at the RUC as general internal medicine, as hospital medicine. And so that has really, unfortunately, allowed for there to be a favoritism to procedural and surgical specialties at the RUC. ACP led the effort at the RUC several years ago to improve E&M payment rates for more cognitively based physicians, and that wasn't just general internal medicine, that was a whole swath of physicians. But unfortunately, what has happened is many institutions did not realize those for compensation for their staff, for their employees, or if they did, they ratcheted up their RVUs proportionally. I got to hear Dr. Asaf Batan, who took over Ariandi Labs after Atul Gawande left it. He's an internal medicine physician who's also an internationally renowned health policy wonk, who is on the National Academy for Evaluation of high-value primary care. He spoke yesterday for our ACP's DC-based policy committees, and you may have seen this. This is the most recent report by that group to improve primary care valuation, and that was released a couple of months ago. What they recommend here is, and hold on to your seats here, is that they want to increase the E&M services by 50%. And they also recommend that the RUC be restored to its advisory only capacity. Now, before we get into the whole divide and conquer amongst physicians, I want to tell you, don't get into divide and conquer. Support each other, because by supporting primary care, everyone will flourish. What we need to do is unite as physicians and push back on the budget neutrality in the physician fee schedule, which is the only portion of the physician fee schedule, of the entire healthcare fee schedule, that is held to budget neutrality. Institutions aren't, pharma isn't, nursing homes aren't, home care isn't. None of the other aspects of the healthcare ecosystem are held to budget neutrality. And that unfortunately has allowed for a lot of divide and conquer amongst physicians, and we have to shake ourselves out of this mode. I talked to my dear friend Dr. Patricia Turner, who is the CEO at the American College of Surgeons, and we are both pushing to stop this pervasive divide and conquer and unite together to push back against budget neutrality. So this is the most recent data from the Kaiser Family Foundation that demonstrates that we do not have the healthiest country of comparable countries in the world, right? When we look at comparable countries versus the US, in terms of life expectancy, our life expectancy is about 4 years shorter. We had a bit of a bump post-COVID, but we are still far lagging behind. But nonetheless, we spend the most money on healthcare. Compared to comparable countries. But when you actually take a look at this data, looking at total healthcare expenditures, and remember that health is more than healthcare, right? That where people live and what their lifestyles are like, and the food that they eat, and the amount of exercise they can safely get in their neighborhoods also contributes to health. We see that the US is spending a short amount of money on those other supports that improve people's health when we compare them to the OECD data, the comparable country data. And once again, we see, the sad news around what's happening in the US in terms of how much spending we are doing per capita. But there is money there. But one of the messages today is that one of the big reasons we need to support primary care is because they are perfectly poised to deal with so many of the things that are taking patients early, that are eating up a lot of healthcare expenses. We take a look at overdose deaths, and we got good news, right, in 2023 finally regarding a decrease in overdose deaths. Our primary care doctors are on the front line of assisting our patients in that. And so we hope that we can have a lot of impact there. We know that for opioid addiction touches many, many families. And my guess is there are some of you in this audience where you have had to usher folks that you know and love through opioid addiction. Who better to do that than the person who has an established longitudinal care relationship, who is trusted by patients and family members? We know that diseases of despair are at an all-time high, and unfortunately, we're seeing this in our younger folks, in our children, in our young adults. The Gen Z generation is felt to be the least flourishing of any generation to date in the United States. Firearms violence, this is a subject near and dear to my heart. I lost my best friend from college to firearms violence in 1986. Once again, our primary care practitioners are poised to make significant interventions in this arena. And we've done a lot in terms of understanding the ecology around firearms violence and how our healthcare system and how our neighborhoods were set up that unfortunately catalyzed these epidemics that we have in many areas of our country. And that this really does impact everyone. We're seeing more and more and more children. It's the most common cause of death in kids being impacted by this, either by being injured or killed themselves or by losing their primary family members. And so I think there's a lot of data here, and I'm going to zip through this quickly, but the message here is that our surgeons don't want to be doing this. Our emergency medicine doctors are by default primary care physicians because patients can't get in to see primary care practitioners, they don't have access, or they just can't find one. And so by default, our emergency medicine folks are seeing so many of the consequences of preventable diseases that should have been handled in the primary care office. Those patients coming into their ER with late stage and horrible catastrophic consequences of these diseases. More than 321,000 U.S. children lost a parent to drug overdose in the decade from 2011 to 2021. And of course, the promise of primary care taken on by some of the largest businesses in our country. Primary care sounds so simple, right? Primary is a misnomer in primary care. That patient walks into your office, could have one of 80,000 different diagnoses. You need to be the smartest person in the room to figure out what's going on with that patient, or to figure out how to figure out what's going on with that patient. And basically what has been said by Walmart and so many other companies that thought primary care looked so easy, they were going to be able to do it like this, is that we are determined that this is not a sustainable business model for us to continue, right? We've known that in medicine for a very long time. This is not a sustainable business model the way that we do primary care. And telehealth, really important tool in our toolbox. There's a lot of concern about what's going to happen to telehealth after the payment for telehealth goes away at the end of September of this year. But we know this is a tool we can leverage for those patients that may not need to come in to see you face-to-face. My husband's a pulmonary critical care and sleep medicine doctor. After an initial visit, he tries to see all of his sleep patients via telehealth when they are stable, because it is hard for them to come into the office. Many of them have transportation issues, and we see this with a variety of other diseases. And our rural communities that are seeing more and more of their hospitals close, patients have to travel hundreds of miles to actually get face-to-face care. But yet, we need to make telehealth a viable model and recognize it not as a substitute for care, but an ancillary tool in that toolbox. So everyone, my message here is that everyone deserves a quarterback team approach to care. Yet a third of our patients have no primary care practitioner. It's only getting worse. I can't even find my husband a primary care physician. I retired from being his on-the-side primary care physician last year, and I found him, actually Matt Watto, who is one of my former trainees as well, was in the same class as, I believe, Mamoon. He and Paul Williams are the Curbsiders, one of a very beloved internal medicine podcast. Matt was my husband's primary care doctor, and he has now jumped ship to go to a different practice where he's not doing traditional primary care. So I'm in the process of finding my husband another primary care physician. And we know that for PTO, for primary care doctors and many other practitioners out there, it to them means pretend time off or pajama time on. I do clinic usually a couple times a month at Temple, and I spend my evening finishing up chart work, reviewing labs, etc. And I just think it is just so exhausting for people that are doing this full time. We need to get a better space. So a shift is happening in how U.S. healthcare is delivered. We see with our new HHS secretary that is very interested in chronic disease and prevention of disease earlier on in treatment course. And so we see an increasing emphasis on that. And we know that primary care is evolving. And that, it used to be that even young folks had a regular primary care practitioner, but Many folks are just doing episodic transactional care, rather having that relationship-based longitudinal care that we know makes a difference as folks age and get sick, to have that person who knows you and that and that patient's trust. And this has been part of the problem with all the distrust that we're seeing in the system, is really the fracturing of those longitudinal primary care relationships. Annually, direct healthcare costs for patients with chronic disease average a little over $6,000, and that's approximately 5 times what it takes annually to care for a person without a chronic disease. And the paradox of and invisibility of primary care, published in a couple of articles, one Annals study and a Health Affairs, demonstrates that you save money and you improve longevity and quality of care when you have a higher density of primary care physicians. Now, these studies were done with physician data, not other practitioners. And so primary care truly is foundational so that the rest of us can flourish. Primary care gets patients right care, right time, right practitioner, right setting, with higher quality and lower costs. And of course, this is Atul Gawande's 2017 article regarding the heroism of incremental care. We devote vast resources to intensive, one-off procedures while starving the kind of steady, intimate care that often helps people more. So this article was written last year talking about the workhorses in healthcare, and that eventually when you don't feed and water them and treat them well, they are not going to flourish. They are going to become ill. They are going to leave their profession. And the bottom line is we're all going to be primary care physicians if we don't do something about this soon. And traditionally we think of primary care falling in family medicine, internal medicine, peds, med peds, quote, general practitioners. Now we've had an expansion of that. But once again, we are just seeing people request for primary care needs to their subspecialists, to their procedurally oriented physicians. There's been a lot of studies that have taken a look at primary care spend in the United States, and here's a chart for you. The bottom line is that's what's really interesting, it's about 5%. If you look at each state and average it, about 5% of the payment system is going to primary care physicians. And we know that overall healthcare spending, overall 5 to 7%, but we know that physician fees are just a small piece of this pie. Yet, as I told you earlier, ironically, we're the only ones that are held to budget neutrality. So we need to unite the House of Medicine and together push back on that, because the problem starts but doesn't end with money. Look at this, 35% of the care that is getting offered in our systems are being delivered by primary care, yet they're getting paid at a 5% rate. Now, this is an astonishing slide. This is from Dr. Asaf Batan at Ariande. He presented this at the Primary Care Collaborative keynote a couple of years ago. And we've got to be able to care for people and meet them where they are. And this is where primary care can really help us with this, because primary care sees many more patients with multiple medical conditions. I find that I am writing on average 4 to 5 active medical problems in every note that I write for patients that I see. And it's only getting worse. Primary care also sees more patients with behavioral health issues in addition to the chronicity. And we know that patients with socio and behavioral issues can be very, very challenging to manage everything else that is going on with them. And so primary care is the solution for life expectancy, and this is from the Besu article from Annals in 2021, demonstrating that we saw improved life expectancy in areas of the country that had a higher density of primary care physicians. And so the Primary Care Collaborative, which ACP is a founder of from 2008, along with our pediatric and family medicine and osteopathic physician friends, does a primary care evidence report each year in conjunction with a think tank at Family Medicine, and talks about the distribution of primary care spend. So we're spending a lot of money on the front end, which is a good thing. We want healthy infants and healthy children, but at a time when we also need to be spending a lot of money as people age, they start to get complex medical issues, the spending paradoxically goes down. And we know that we are having more and more primary care physicians retire early, cut back to part-time, go into direct primary care practices, or some permutation of that. Or just leave medicine entirely and go into a different profession. So we want fewer people hospitalized, and there is obviously demonstrable benefit for why primary care can help to get fewer people hospitalized. But right now, our payment system, again, is perversely incentivized for patients to get sick, to get admitted to the hospital, to need procedures, and need surgical things done to them. We've got to break this cycle of dysfunction. Our EM colleagues are doing so much primary care and seeing so many things, and their time is getting taken away from patients that they really need to be concentrating on. And likewise, this is a matter for all of us. We all want all of our patients to have appropriate access at emergency rooms. We want that for our families and neighbors as well. But because of the primary care crisis, patients are going to the emergency room for primary care. And so there's been a lot written around the area of brownout and burnout and professional dissatisfaction. And it really comes down to autonomy and control. There's been a lot of studies that have demonstrated that the very few and far between independent practitioners that are out there still running their practices at ACP, about 15 years ago, 80% of our members were independent practitioners, 20% were employed. 15 years forward, it's the complete opposite. 80% of our members are employed, 20% are still independent practitioners, but the data demonstrates that because you have that autonomy and control, if you are running your own practice, which is extremely challenging, but you are much more satisfied in those practices. So primary care is barely surviving and definitely not thriving, because 60% of primary care practices report open staff positions they can't fill. About 40% of primary care practices report open clinician positions they can't fill. And of course, the brownout, burnout, and professional dissatisfaction of all of our front-facing healthcare professionals is at an all-time high. A little bit better coming out of COVID, but is still extraordinarily high. So we've done some studies. ACP administers the in-training exam for internal medicine residents, and we've seen tremendous decrease in interest in general internal medicine careers. And remember that for each hour that a primary care physician is spending in direct patient contact, they are spending 2 hours on the back end charting, doing prior auths, et cetera. And once again, they're doing 30 to 35% of the total work in the outpatient setting, but only getting 5% of the funding. So this is something that ACP has been very much pushing at state levels as well as at the national level. And the biggest thing, again, that when you talk to your non-primary care colleagues is to say, we need primary care practitioners because everyone is going to end up being a primary care physician if we don't intervene in this crisis. And this, once again, is talking about the different coding. I mentioned the different coding changes. There's a lot around comprehensive primary care now as a carve-out for capitation that is being pushed. There are several codes that have been added on. But I don't need to tell you, you don't need an MBA to recognize that if you're an internal medicine trainee, you've got $500,000 of indebtedness between undergraduate and medical school, which is about the average these days. And you take a look at a 40-year career between becoming a cardiologist or being a general medicine physician, that's a $4 million, maybe $8 million delta, right? So you don't need to have an MBA to do that math. But it's not just about the money, right? It's about the satisfaction of practicing in a way where you have control and autonomy, and by far and away our primary care practitioners have the biggest burden of prior auths, et cetera, that administrative burden laid at their feet. And we need our organizations to truly address this. I'll give you a quick example from a former resident at Temple and one of my associate program directors who ran our clinic, Dr. Elizabeth Leilani Lee. She wrote up in the SGIM forum last year about inboxologists. Remember, subspecialists, surgeons, they get a decent amount of messages. No one gets the amount of messages that our primary care practitioners do. And guess what? If you're a woman primary care practitioner, you are on average getting 25% more portal messages than your male colleagues from both your male and your female patients. So innovative programs with a business plan around unleashing RN inboxologists or someone else with comparable training to take that off the hands of your primary care frontline practitioners so that they can focus on direct face-to-face patient care, improve access for those patients, is something that the smart healthcare systems are doing, and that is exactly what Dr. Lee is now doing as the Chief of General Medicine at the Cooper Rowan Health System in South Jersey. And of course, prior authorization. This is something that we are just standing up and down and shouting about because it is a real issue in direct care. We are spending way too much time for the majority of denials are going to end up getting overturned. And we know that the payers are not transparent about criteria that they're using. They frequently don't have folks reviewing cases that have an appropriate clinical skills training in order to review them in a data-driven, evidence-based way. And the majority of denials, we know, get overturned, but sometimes it's too late for that patient, right? We were just hearing yesterday at our Medical Practice and Quality Committee meeting where we're writing a paper regarding including some of these aspects that when the patient has been dead for 3 months, it's too late for the prior auth to finally be approved. And most of our patients don't have the resources to seek out-of-pocket care. So prior authorization is by far and away the biggest burden for our clinicians, both in national surveys and in ACP surveys. And basically, prior auth, durable medical equipment, Part B drugs, et cetera. Prior authorization is also really interestingly very different across the payers. And for example, Kaiser Permanente, which is quite an integrated system, they have one of the lowest denial rate for prior authorizations in the U.S. Healthcare systems. And again, once again, it's because they trust their practitioners to practice evidence-based care. They have transparent guidance, transparent clinical guidelines, guidance statements, et cetera, that they expect folks to be adhering to. But once again, they're only clinical guidelines. You're always going to have to deviate occasionally from those guidelines for a particular unique patient circumstances. So the worst players here are Centene, CVS, United Healthcare, Cigna, Blue Cross Blue Shield, and here's the Kaiser data, which is much lower. So what my message here is to all of those other plans, what are you doing wrong that Kaiser is doing right? And the other thing that was very interesting is that with the accountable care organizations, the physician-led ACOs and the ones that had a preponderance of primary care physicians in these accountable care organizations delivered higher quality care at lower costs. So making care primary is something ACP and NCQA put in as a payment model. We'll see where it goes. There's a lot of upheaval happening at CMS and CMMI as we speak. But we felt it was very important to recognize that, that we don't practice in a vacuum and that we really need our neighbors in the medical neighborhood. So we put together this PTEC in conjunction with ACP's Council of Subspecialty Societies. So we have the 24 IM medical subspecialties in this council. They're all represented. And we work together to put what got a 100% score. We'll see what happens with this. There's also a conjoined bill in the Senate with both a Republican, it's now the Cassidy White House bill. Cassidy's from Louisiana. He's a Republican. Senator Whitehouse is from Rhode Island. He's a Democrat. So there is a bill around strengthening primary care. We're not sure what's going to happen with this because it's been kind of a black box to see what's going on with payment models at CMS and CMMI right now. And we also know that traditional Medicare also has a lot of issues in terms of payment. Although we do know that for Medicare Advantage programs, we see the profits that the three big players there are making. We know what goes on with the HCC coding to add medical complexity, et cetera. So there is money in the system. We just need to figure it out. So the Senate Finance Committee is stepping in. They're going to be meeting about this. And we need to make sure that primary care physicians have sustainable payment updates. You know, we believe it's very important that there be proactive payment to primary care practices and that there be appropriate carve-outs for folks with medical complexity, because we know that it is those 5% of patients with high medical complexity that are accounting for 3/4 of the cost in the healthcare system. So how do we sort of switch this paradigm? You're all at an academic medical center. I urge you to read Bob Wachter's article from Health Affairs. He's considered the, quote, father. Don't call him the grandfather of hospital medicine, please. Call him the father of hospital medicine. He's the chair of medicine at UCSF. And he wrote that many attributes of academic medical centers that have served them well in the fee-for-service system may hinder the transformation needed to succeed in value-based care. Much of the underperformance of AMCs may be explained by two core competencies that academic medical centers lack: the limited ability to redesign clinical workflows and inability to change their economic relationships with their own subspecialists and primary care physicians. He nailed it. It's about the money. When people tell you it's not about the money, it's always about the money. So this is why we have to work together to push back on budget neutrality, and we need to make sure that our health systems don't pit practitioner against practitioner. But we know our academic health systems have their own challenges, right? Academic health centers are 6% of the hospitals and healthcare systems in the United States, yet we account for caring for over 40% of underserved folks in rural areas and inner cities. And we have seen margins drop significantly, but better is possible. And I'm showing you this pie chart again to talk about this is a small part of a very, very large, over $4 trillion pie. The Inflation Reduction Act, I was glad to see that the current administration is continuing to do pharmaceutical price negotiation. And this is, to me, probably one of the most astonishing slides. I was a medical student. I graduated in 1985. DRGs came to fruition while I was on my clinical training as a medical student. 3,400% increase in administrators over the past several decades, whereas the physician growth rate is essentially flat. And it is estimated that for every full-time patient-facing clinician, primary care clinician, we need 12 to 15 administrators are standing behind them at various levels. So the financial cost of administrative complexity burden in a physician organization is huge, just like the turnover of practitioners. And there's some great articles around administrative costs. This is David Himmelstein and Steffi Wolfhander's article, and this still stands. If you take a look at the United States versus Canada, you can see that we're spending about 3 times more on administrative costs. There's something going on here. And so ACP has written about financial profit in medicine. We know that there are people skimming a lot of money out of the healthcare system. They are siphoning it off, and it's not going directly back into patient care. And even though there is a medical loss ratio rule of 85% of the payers' profits need to be turned back into care that benefit patients, we know that that is maybe not happening to the degree that it needs to. We also know that this is happening. There's high competition for patients, especially for those higher end services like transplants, et cetera, that are so valued in our healthcare system, whereas primary care doctors say, we shouldn't have had to send that patient for a heart transplant. We should have been able to prevent those diseases that created their heart failure, et cetera. If you want to do something on a weekend, look up this article from about 15 years ago in the New York Times Sunday. It was, is this a hospital or a hotel? And it shows you about 20 pictures of hospitals versus hotels, and you have to guess which is which. So it's an interesting exercise. I didn't do so well on that. And of course, private equity. I just saw the closure of Crozer-Chester Health System in Chester, Pennsylvania, which closed on the heels of Delaware County Memorial Hospital. There is essentially no place for folks to go within a large swath of southeastern Pennsylvania now, because the private equity company, and apparently the Department of Justice for Pennsylvania has been asked to investigate this, just like the Hahnemann closure that happened in Center City, Philly. We've seen a lot of closures of hospitals, particularly in underserved and rural areas in Pennsylvania, like in other states. And the issue around private equity and what is happening in both outpatient practices and healthcare systems is very, very concerning. And we need to keep our eye on that. Financial gains in healthcare, doing well without doing good. A great article from about a year ago in the JAMA forum, where we're seeing what's going on and how much money is getting sucked out of the system that is not going back into healthcare, but is lining the profits of various shareholders. The other issue is inclusion. You know, when people say, oh, what's this DEI stuff about? I say, this is about making sure that all of our patients have the best possible outcomes they could possibly have. This isn't woke. It's awakened to understand that folks are starting behind in many ways and might need additional supports or different interventions to get them to the same outcomes as other patients. So there is a high cost of failing to address health inequities. And of course, many of these studies, sadly, have been recently stopped. And we're just going to be even worse off. It's not going to save us money. It's going to end up costing us a lot of money in the long run. The same thing with not addressing the epidemic of professional dissatisfaction. There is great data that the more satisfied your front patient-facing practitioners are, the more adherent your patients are, the more satisfied physicians are, the more satisfied patients are, the less turnover you have of those clinicians. And we saw, of course, the devastating effects of COVID-19. This was an article that a bunch of us wrote early on in the epidemic. And additionally, we have put forth a lot of proactive principles, including physician-led team-based care. And optimizing team-based care, such as the use of inboxologists, the example I gave a little bit earlier. The other thing is that one of the problems with not attracting people into primary care is not this whole bevy of things we've already talked about, but we're not exposing them early on in their undergraduate medical career, or maybe even earlier than that, to functional primary care ambulatory settings. And we need to all think about that. We know that our clinics sometimes are the most under-resourced places in our system. And we need to make sure that our medical students and our trainees are exposed to high-functioning ambulatory systems. And I've always worked in a team in our comprehensive HIV practice. We have that same for our general internal medicine practice, and it really allows people to leverage their skill sets. We've got to work together with our co-healthcare professionals and figure out how to best leverage their skill sets to improve patient care, improve efficiencies, improve outcomes, and decrease the cost. Now I'm going to leave you with a few slides around our surgical friends are figuring this out. This was Robert's study from JAMA Surgery a couple of years ago, which demonstrated that folks that needed acute surgical procedures who had established care prior to that and then followed up with their primary care practitioners had better outcomes. And now we're finding the same among adults 65 and older undergoing cancer surgery. 90-day mortality, of course this is adjusted for all the factors, for patients who had continuous primary care was 2%. It was 3.8% for those who did not. So we're seeing more and more data support the importance of primary care for everyone in the healthcare system. Waste in the U.S. healthcare system is felt to be huge. What's going to happen with AI? Eric Topol was ACP's speaker in 2024 at our meeting, and AI is, again, a tool in the toolbox. It is not going to supplant much of the things that we can do for patients. We've got to figure out how to leverage EHRs better. I don't know if you're using technology here for notes, but a lot of centers are now using AI technology to create their encounter notes, and I think with an asterisk, that can be a very good thing. The issues that I worry about, of course, are patient privacy, but I think that leveraged correctly and deployed correctly, that could be great. And AI can really help us here. It can help us in fighting back for the prior authorization and the other denials that we get. They're using AI. Why shouldn't we be using AI to push it back? So I think that that's something that we can really, really leverage. And the other little hint I'm going to give you that I always told the residents is when you get a denial on a patient, you ask that person, I need the name and the medical license number of the physician that issued this denial. I'm putting it in the patient's chart. I have done that for about 30 years, and I can tell you it works remarkably well. So say my name. Our most precious resources are our healthcare practitioners, and this is the sad news about what is happening according to our in-training exam. Late 90s, 60% of those third-year residents taking that exam were interested in GIM careers, and we are now down to about 9% on our most recent in-training exam. And the National Academy has said we've got to figure this out. We need high-quality primary care, and this has got to be a multi-pronged, team-based approach that is centered around patients, rather than being that paternalistic, it's always about us, right? To getting to a better place for primary begins but doesn't end with better exposure, experience, resourcing, and financing. And we've got to work at the local, regional, state, and national levels to push back on budget neutrality. So when we take a look at these questions that I started this off with, administrative costs are $800 billion in our system. Low-value care, a minimum of $250 billion. Not addressing health equity, another $750 billion. Turnover in frontline practitioners, diseases of despair and violence, there's overlap in these numbers, but we could save huge swaths of money by finally addressing these big problems. Now, you may have noticed I don't use the word provider because ACP is making healthcare human again. We are physicians, not cold providers. Remember, we do not want to corporatize medicine, right? They are our patients. They aren't customers. They aren't consumers. They are our patients, and we are their practitioners. So please take the pledge with me. I pledge not to use the word provider when referring to physicians and other healthcare professionals, and further encourage my colleagues to do the same. So please, please help to support your fellow practitioners. It's going to make a difference for our patients in the end. Thank you for your attention, and I'm happy to take questions.
Thank you, Dr. Moyer, for that fantastic talk. Real call to arms. So we have a few minutes for questions. I'll open up to the audience. Sorry, Brad.
You know, that was a great talk. So you highlighted two celebrities in your talk. So Rodney Dangerfield, who famously got no respect, and Tom Brady, who famously gets a lot of respect for leading a very high-functioning team.
Mm-hmm.
So as frontline providers, and particularly as younger providers, what are your, who aren't at the table where these financial decisions are being made, what are your suggestions for folks to start moving this perception issue, perhaps as well as the monetary issue?
So we're,
Can you just repeat the question?
so the question is, how can young people and folks who are not at the table where these decisions are getting made have impact? And once again, I think that, we're supposed to be evidence-based and data-driven. Pushing back with evidence and data is very, very critical. Join those councils and committees, those things where you think, like, I don't have a single extra minute to do anything. But I think if you take a look, we have resources. I know medical subspecialties have resources about doing impactful quality improvement that will then translate to better outcomes for patients, but better outcomes for the bottom line. And the way, for example, that Dr. Lee did this exactly when she put her business proposal together regarding hiring 9 inboxologists for her almost 100 practitioners in her division in South Jersey. She took the quality and the human and the satisfaction and the turnover elements that they were seeing and sort of put dollars around that. And it was a no-brainer for the system that this should happen. So I think it's to know your data, talk to folks that are experts in the area, and then figure out how to put a compelling business plan together. I want you all to read our collective empowerment paper that was just published in Annals of Internal Medicine Monday evening. It was a work of our Health and Public Policy Committee, our Medical Practice and Quality Committee, our Ethics, Professionalism and Human Rights Committee, and our Professional Satisfaction and Fulfillment Committee. We have several suggestions in there and really want to push our organizations to get back to physician empowerment, to be sitting at the table, to have a really empowered medical staff, to have practicing folks on fiduciary boards for organizations. Because I think you make that case with the human and the money, the financial implications. And I think that what's important is that younger folks have more power than you think you do. Having the leaders of your division and department and your organization have a kitchen cabinet of people on the front lines that represent all types of diversity at your organization. Mayo Clinic has started this program where they have designed teams to go out to dinner with a hospital executive, somebody, the CMO, the assistant CMO, and it's been very, very successful. It has improved systems there, and it has proved the satisfaction of professionals that are working on the front lines of care. So I urge you to lean in and get involved and to put a little bit of extra energy in on the front end, because it is going to reap you a lot of benefits on the back end.
Wonderful talk.
Thank you.
So, in the last 5 years, I've been amazed at the number of provider physicians locally that have retired, but even more so in the last year, the number of concierge that they brought their practice and adopted that model. Are you seeing nationally more primary care docs moving to that? And do
Yeah.
physician-owned practices and hospitals have a financial bandwidth?
Yeah, and remember that systems are now doing that. I know someone who was a longtime general internal medicine practitioner at a major health system in Philadelphia who is now part of their, quote, concierge, direct primary care practice. And that's because people have had to do it. That's the only way to sustain it. I am not aware of a comprehensive study that is currently happening there, but my family medicine folks have some data around it. And if you come up to me afterwards, I'll give you my card and you can email me and I'll see what I can dig up for you. But it is definitely happening. And it is happening because for the exact reasons that we just talked about. And there's been a real, I think, debate between ethicists, people that are bioethicists in healthcare and practitioners, and the folks that are on the medical practice side. And there is that natural tension that, oh, well, no, we don't approve of DPCP. What we said is, our policy positions have been, if that's the way you're going to keep somebody in the profession, and that is the only alternative that they have, and it's the last sort of thing standing for them, better that they still continue to see patients, even if it's a smaller group of patients, than leave medicine completely. So this is a real challenge. But we're also seeing that a lot of the private equity companies that tried to get their hands in primary care recognize that it is not going to be the profit machine, right? That some of their dermatology practices or their other types of healthcare that they've been involved in, because primary care is a misnomer. It's really complex. But I'll see if I can dig up some data for you.
Dr. Moyer, thanks for coming. We're launching a new kind of residency program in a large community hospital setting that's designed to produce and train for general internal medicine. Essentially, in a nutshell, it's reducing some of the ICU rotations, a lot more emphasis on chronic disease management and timely outcome setting in a comprehensive way. So we're just starting that journey. Our first class launches here in 2 months. But have you seen nationally other programs that have done that and any early outcomes of that approach to trying to change not just the competence,
Right.
but also the adoption of general internal medicine?
So teaching health centers, of course. So the question is launching a new program that's much more focused on outpatient internal medicine and the integration in the community. So teaching health centers, for example, the Wright Center. I will connect you if you come down afterwards. Linda Thomas Haymack, who is our governor for the Pennsylvania Eastern region, is the executive director at the Wright Center in Scranton, Pennsylvania, which is a huge teaching health center which has that exact type of residency. I think it's probably one of the most established ones in the United States. So we're seeing more and more of that, but here's the problem. Who's going to fund it? So the way that GME dollars have been appropriated were through the Balanced Budget Act when Clinton was president in 1996. Remember, those were never increased. So even though we've seen a 30% increase in residents and fellow training slots, that's all been borne on the back of healthcare institutions. And of course, many of them knew they were going to get a lot more money by adding orthopedic surgeons and urology trainees than they would primary care. So there's that whole other now focus on community health centers and teaching health centers. But the problem with teaching health centers is we don't want that money siphoning off already appropriated GME funding. So what we have, our position has been, yes, please expand the teaching health centers and these types of programs and initiatives. We need more primary care doctors and they need to be better distributed, right? Because there's maldistribution as well. But we don't want that money coming out of already appropriated GME dollars. It has to come out of new money. All bets are off now. We're really not sure what is going to happen with GME financing. It has been a contract with society. We're the only profession that has that type of system. And I'm reading tea leaves, I'm very, very concerned about what might happen to GME dollars, both at the federal level and then the implications for the state dollars. But let's talk afterwards.
Thank you again, Dr. Moyer, for that excellent talk.
Thank you.